Hi everyone, I hope you're all doing good. This is my presentation of septal defects of the fetal heart on ultrasound. So the objectives for this PowerPoint is to discuss normal fetal heart embryology, review the fetal heart circulation, and then identify septal defects, which we're going to go over three: atrial septal defects, ventricular septal defects, and atrioventricular septal defects. So before we can start the pathology, we have to understand the embryology. So the early fetal heart is a basic tube, and this tube basically starts to beat about the 21st day, and that's about 3 weeks. Where it develops the heart, it's going to be the region in the embryonic disc at the cranial rim, and it's going to grow here. And as the heart develops and the embryo develops, the heart will assume a normal position ventral to the forming forebrain and foregut. So when I say that the heart's a basic tube, this is a diagram of what I mean. So there's different areas of this fetal heart, and it's a tube, and we're just going to go through those areas. The first area is the sinus venosus, and this is the collecting compartment of the heart. And when I mean collecting compartment, it's going to have oxygenated blood from the placenta and deoxygenated blood from the embryo, and those are going to mix here. So this is going to form the superior vena cava and part of the right atrium. Next is the primitive atrium. This will further divide into the left and right atria. The primitive ventricle will further divide into the left ventricle. The bulbous cordus, this will further divide into the right ventricle and also contributes to the aorta. The truncus arteriosus becomes the aorta and its branches. And if you're looking at this diagram, you're like, oh, what are these purple dotted lines? Well, those are the fibrous skeleton, and this is going to be the site for this future valves. So we know that the heart's not going to stay a tube forever, so at some point it must bend and fold, and that happens at day 23. The bulbous cordus will move down and toward the surface, being on the right side, and we know that the bulbous corpus will form the right ventricle. And next, the primitive atria and the sinus venosus will move up and toward the back, and these will form the right atrium. The primitive ventricles, they will move toward the left because that's forming the left ventricle. And the truncus arteriosus divides and forms the primitive aorta and pulmonary trunk. So at this point now, the heart's folded and it's just one big empty space. So we know that the septums must come and divide into the four chambers. So first, the atrium. The septum primitive grows toward the endocardial cushion, and that's the area between the atria and the ventricles. And then another septum grows from the endocardial cushion, but does not connect. And at first, this creates the foramen secundum, and that happens in the 4th week. By the 6th week, a second septum develops called the septum secundum, and that's going to create what we know as the foramen ovale. Moving to the ventricles, the separation of the ventricles happens in a similar way. A muscular interventricular septum grows from the floor of the ventricles, and this happens about the 4th week. And by the 5th week, the aorticopulmonary septum is formed by the truncus arteriosus. And both of these septums will fuse, and that's what separates the right and left ventricles. So the fetal circulation, this is just going to be a quick overview and review. So looking at this diagram, we know that the oxygenated blood comes from the placenta entering the umbilical vein, and some of this will go to the left portal vein of the liver, and a majority of it will go to the ductus venosus, which is a shunt away from the liver because it's not fully functioning. So this shunt will carry the blood to the IVC, and the IVC will carry the blood to the right atrium. And we know here that there's a foramen ovale separating or in between the right and the left atria. So a majority of the blood will go there to shunt the blood away from the immature lungs. but some of it still gets pushed from the right atrium to the right ventricle and goes towards the lungs. But there's also another shunt here called the ductus arteriosus, which will take a majority of that blood away from the lungs as well. So here's a normal 4-chamber view. This is a normal heart. We're able to identify the different areas of the heart because we can find the spine and the aorta, and we know that the closest portion of the heart is the left atrium to the aorta. So moving on to pathology, the first pathology we'll discuss is atrial septal defects, and this is a failure to close the communication between the left and the right atria. This is one of the most common types of congenital heart defects and occurs in about 25% of children. There are 5 different types of atrial septal defects: patent foramen ovale, ostium secundum, ostium primum, sinus venosus, and coronary sinus defects. Small arterial septal defects are usually spontaneously closed. However, large defects will not close, and they'll require some sort of surgical intervention. If this doesn't happen, other complications can occur, such as stroke, dysrhythmias, and pulmonary hypertension. So diving a little deeper into these different types of defects, ostium secundum. This is a defect where there's an increased reabsorption of the septum primum in the atrium's roof, or the septum secundum does not occlude the ostium secundum. So these types of defects are usually associated with syndromes such as Noonan's, Treacher-Collins, and thrombocytopenia absent radius syndrome. Ostium primum defect. This is the third most common defect in the atrial septum, and it's due to failure of the septum primum to fuse with the endocardial cushions. This is more common to happen with other ventricles septal defects, so it's usually in the world of atrial ventral septal defects. The coronary sinus defect. The coronary sinus is a vessel that runs along the groove between the left and the right, the left atrium and the left ventricle, and it collects veins that represent the venous return of the heart muscle. So the coronary sinus is normally, it drains into the floor of the right atrium above the septal leaflet of the tricuspid valve. This defect will create a hole between the left atrium and the coronary sinus, and this is called unroofing, and it creates a communication between the left and the right atria. The last defect that we're going to talk about for atrial septal defects is the sinus venosus defect, and there's 2 different types of these. There's a superior and inferior, and these actually don't involve the septum at all. They're caused by the overriding of either the superior vena cava or the inferior vena cava. So superior defect, that's the overriding of the superior vena cava, and the inferior defect is the overriding of the inferior vena cava. And this diagram over here shows the superior vena cava overriding. And so it'd just be the same for the inferior vena cava for an inferior defect. The inferior defect is less common than the superior defect. So these are just examples of the different types of atrial defects that we talked about. Up here, there's a secundum and a primum. These are kind of hard to differentiate between the two on ultrasound, and they can be overlooked as just a regular foramen ovale. So that's kind of something to look out for. Down at the bottom here is a coronary sinus defect, and this large one I liked because it shows what's called a common atria, and it just looks like one big atria because there's no septum dividing the two. Moving on to ventricular septal defects, this is a direct communication between the left and the right ventricles. So in a fetus with ventricular septal defect, it can have 1 or more holes in different places of the ventricular septum. The most common locations, there's 4. The first one is the coronoventricular or the subaortic ventricular septal defect. And in general, this is a hole where portions of the ventricular septum would meet just below the pulmonary aortic valve. So this is a lower communication. The perimembranous ventricular septal defect is a hole in the upper section of the ventricular septum. An inlet ventricular septal defect, this is a hole in the septum near where the blood enters the ventricles through the tricuspid and mitral valves. This type of ventricular septal defect also might be part of another defect called atrioventricular septal defects, and we'll talk about that in a little bit. Lastly is muscular ventricular septal defects, and this is a hole in the lower muscular part of the ventricular septum, and it's the most common type of ventricular septal defect. So here are some images of the different septal defects in the ventricle. So this first one up here, inlet, muscular, perimembranous, and the subaortic. I just like this picture because it's easy to miss different types of defects. This is an example of a muscular ventricular septal defect. And it looks like in the grayscale image that there's nothing there, it's fine, but then they threw color on it and you can see that it is patent. So the last thing that we're going to talk about is atrioventricular septal defects. And this is a general term for a group of rare heart defects that are present at birth. So these are septal defects affecting both the septum of the atria and the ventricles. So infants with this defect are improperly developed or have improperly developed atrial and ventricular septa. There's a variety of different classifications, but the most common they're usually divided into partial and complete forms. Partial is a defect in the primum or inferior part of the atria septum with no direct intraventricular communication. So this is a defect of a hole in the atrial septum and the ventricular septum, but they're still divided into 4 chambers. And then a complete defect, there's a large hole between the portion of the atria and the upper or inlet portion of the ventricles, and this is associated with a significant abnormality. So this is just basically, there's no middle part, there's no division, it's one big chamber. So here's a example of a complete septal defect. You can see that there's no septum dividing between the ventricles and the aorta. Fetal outcomes. All septal defects are the mixing of oxygenated and deoxygenated blood. And when that happens, this can lead to congested heart failure. Another outcome can indicate trisomy 21 if you have a atrioventricular septal defect. And this chart over here, I found it with my research, and it just shows different types of anomalies that were found during a fetal scan that made them make sure that they looked at the heart for sure. And if you can see that a lot of these are can be associated with some sort of chromosomal abnormality. Moving on to risk factors for septal defects. So if this is not chromosomal or congenital, it can be caused by a maternal factor. And this is a hyperlink to a really nice chart that I found, and it goes into detail about how much smoking can affect and what type of defect in the heart it will cause. So I just pulled the top ones that I saw. So there's smoking, drinking, the use of marijuana, obesity, stress, and family history. So go ahead, check out that link. It's really interesting. In conclusion, this presentation served me as a review and a study tool for this upcoming exam. I was able to take what I learned from the lectures that we were we were given and was able to do my own research to add more details. For an example, I was able to dive a little deeper with the atrioventricular and both the atrioventricular septal defects. For going a little more into example, for atrial defects, I was able to learn and do more research about the most common types, such as the ostium primum and the ostium secundum, and learn a new one with the sinus venosus and the superior and inferior defects. Moving on with the ventricular septal defects, I did not know about the perimembranous ventricular septal defect, so that was interesting to learn about as well. I hope you guys enjoyed listening to my lecture, and let me know if you have any questions. Thank you.